Okay, good morning, everyone. I think we'll get started. We have a great program for you today, and I don't want to get too far behind schedule. I'm sure some people will be coming in while we're starting, and that's wonderful. We welcome everybody. So good morning. On this beautiful Saturday, I appreciate your coming out so early. I'm Terry Grebe. For those of you who don't know me, I'm a geneticist here at Phoenix Children's Hospital, and I'm the director of our 22Q clinic. And it's my pleasure to welcome you to our 4th annual 22Q Family Symposium. I recognize many of you in the room, but for those of you who are new and joining us for the first time, I hope this will be a helpful and informative session for you. And I just realized I don't have my glasses. Okay. Each year I've chosen a theme for our conference. The first year we really focused on the main medical issues associated with 22Q, including cardiac and palate issues. And our second year we talked a little bit about some less common but still prevalent medical problems, including hormone issues, immune problems, and ear, nose, and throat issues. Last year our focus was education. If you missed any of those, I'm happy to tell you we have most of the sessions on CDs that you can borrow from our Emily Library. Last year's education session was really helpful. This year I felt it was time for us to focus on the next phase, transition through the teen years and into adulthood. So all of us who have children know how rewarding as well as challenging it is to parent a child. I think it's somewhat a new experience for most of us that first time, and it's just the most amazing experience, but also sometimes the most terrifying. I know I have had those moments myself as a parent. But for anyone who parents a child with a chronic condition such as 22Q, that job and experience may be exponentially more challenging and full of uncertainty. If you have a child with 22Q, you may face one or more heart surgeries for your child, palate surgery, ongoing therapies, some challenges with education, and different hurdles that you have to go through. And I'm sure you've experienced if another parent tells you they know what you're going through, you know that that's impossible. No one who hasn't gone through this experience can ever know what you are experiencing. Likewise, when I meet families in clinic, I know I can't possibly know what they're going through. It's my job, and I try to give them as much information as I can about their child's condition. We talk about the medical problems, what type of evaluations are helpful, what therapies might be helpful, and I try to tell them, what to expect down the road. But while I say that I can give them some information, I always say I don't have a crystal ball, and there is no way I can tell you what your child's going to be like in 1 year, 2 year, 5 years, or as an adult. No one can tell you that. But what I can tell you, and I do tell them, is that you as a parent have more impact on your child's outcome and future than any of us in the medical field. You make a huge difference every day in your child's life, and I hope you know that. And that anything that you do is much more than what we publish in our medical journals. So what I hope we can do here today is, through our presentations, give you some information, some guidelines, a roadmap, some tools to really empower you to help your children through these hurdles at all ages, from infancy through adulthood, and just to help them transition and be the happiest, best person they can be. So today, our theme is Transition to Success. I'm really excited because I've invited some superb speakers. You're going to hear first from 2 members of my team, my core team, who've helped me along the way, who put up with my nagging through the years, over the last 4 years. Dr. Devinder Singh, our Chief of Plastic Surgery, Dr. Stephen Pofall from Cardiology, and they have some great information to share with you. My clinic could not run without them. And then we're going to take a little break. The second half of our program, I'm very excited to have our keynote speaker come, Dr. Ann Bassett from the University of Toronto. She's the foremost expert in mental health issues related to 22Q. She just came in late last night from Toronto, so I'm really thankful that she was willing to get up early and come today. She'll be here at the break and happy to talk to us. I'm also delighted that we're going to have a speaker from the Arizona Center for Disability Law, Donna Powers, who's going to talk about disability services and vocational training. And then we're going to wrap it up with attorney Emily Kyle, who's going to talk about guardianship, medical power of attorney, and estate planning. So we have a really great session and a lot to hear about. So before our professional speakers, so to speak, come to the podium, I have another professional person I'm thrilled to introduce to you. someone who's equally important to our 22Q program. If the people that I've introduced so far are the core of the medical group, she is the heart of our 22Q medical community. For the past 4 years since we started our program, she has come to virtually every clinic every month, and many of you know her already. She's had lunch with the family. She talks to our families about our support group, signs you up for our social events, and lends support and her own personal story. She's just been amazing, and as well as a supporter, she's a tireless fundraiser for our clinic. Without her help, we couldn't have our speakers here today or this conference at all, because it's as a result of her efforts and yours that we've raised enough money for the conference. So what can I say about her? She's amazing, wonderful, and I'm so lucky to have her on her team. And I'm thrilled that she's finally allowed me after 4 years to twist her arm to come up and tell her story. So let me introduce to you Kelly Calcaterra.
Thank you, Dr. Grebe. I am by far no expert. Let's just start right there. Maybe about chairs and furniture, which I'll get to here in a minute, but good morning. My name's Kelly Calcaterra. My husband, David Calcaterra, is also here. We had our first son, Charlie, who's the adorable kid in the picture with glasses on, about almost 16 years ago. He'll be 16 in November. He has 22q11.2 deletion syndrome. We didn't learn about his condition until he was 4. By this time, our second son, Ryan, who's a typical kiddo, he was 18 months old, the other adorable child you see in the picture. We live up in North Phoenix, and we have a beautiful and wonderful life, with the exception of that we're going to have 2 teenagers here very, very soon. My husband and I met about 20 years ago, and we both work in architecture and design industry. 14 years ago, I started my own business as a sales rep for commercial furniture. And seriously, I usually have about 2 to 3 chairs in my car at any one time. So I'm an expert in chairs. Any questions about chairs? Just ask. I have a job that really keeps me very busy, and I have to travel for it, but this same crazy job allows me to come to the clinic every month and do what I need to do for my family, and hopefully for the community of 22Q. So many of you know me as the lady who emails you all the time, or who posts stuff on our group Facebook page. Or I get asked a lot if I work at PCH because I'm always hanging around here, especially on clinic days. The reality is I'm just Charlie and Ryan's mom, and I just want to be involved. It makes me feel good. So thank you for letting me share my story today. As I tried to come up with how to tell a story, our story, I kept thinking about an article that I came across many years ago. And I'm going to assume that many of you have seen this article as well. It really spoke to how I felt as a parent with somebody with special needs. It was as if I wrote it myself, but I can't write. So you probably have either seen it or heard it, but it still resonates after all of these years. So it's here's some pictures. I thought I should show a little bit more of my beautiful children. Ryan is up on the upper left with his doting brother looking on. They don't look at each other like that anymore. First day of school over there on the right-hand side. And then a little bit of an older picture in the car. We're usually driving to soccer games or baseball games or whatnot. So the blog post that I mentioned that really spoke to me was written back in 2012. It's called 7 Things You Don't Know About a Special Needs Parent. And if you haven't seen it, I encourage you to take a look. But it really was meant to inform parents of children without special needs what it was like, right? And caregivers too. Obviously, it's our own reality. You know, we are just parents and doing the best we can with our children. But these 7 things I tried to dive into a little bit And thanks to my husband, who always grounds me and keeps me from diving off the deep edge, basically said, maybe look at these 7 things on a positive note and how these things actually have helped you through the years or have helped Charlie. So I'm just going to go through the list really quick. I'm tired. That goes without saying, right? I'm jealous. I feel alone. I'm scared. I wish you would stop saying. I'm human, and I want to talk about my kid, but it's hard to talk about my kid. So, with that said, first thing, and I have a son, Charlie, who loves memes. So, in honor of Charlie, I thought I'd do some memes today. So, I didn't even know what memes meant until a short time ago. So the first thing, I'm tired. Obviously, this one's pretty easy. We're all tired. It's actually very early on a Saturday, so we're definitely all tired. But I could talk all day about all the things, of course, that make me tired. But I'm going to focus on one thing. So can the therapists and doctors just quickly raise their hand that are in the audience? Okay. Could you please plug your ears right now? Just don't listen. And I was actually talking to some parents out front just before this conference started. I'm going to focus on just one thing that makes me tired, and that's the appointments, right? All the doctors and therapists, they do an amazing job, but the coordination of scheduling and going to all of these doctor visits and then the follow-up visits and the procedures and the service meetings and the IEP meetings and the reviews and the forms and the evaluations and the reports, it's exhausting, right? And probably the most difficult part of all of those is they constantly remind me of all the things that my kiddo can't do well or that might not be going so great. So it's really tiring. But, okay, doctors and therapists, you can start listening now. The same tiresome coordination of meetings and paperwork has also helped my son develop and receive great care and great services over the years. Today, he's graduated from some of these services and doesn't have to see some of the doctors. And that's some hope. I know in my heart that all that pushing, all that time, all those filling out of forms, all the money, all the time, the pushing, the energy, it's made a difference. The 22Q clinic here at PCH has saved me a ton of time, right? When we were diagnosed back in 2006, my pediatrician had never heard of 22Q. We didn't know anyone who had 22Q. We didn't know any doctors. We were pretty much on our own. We had to figure out where to go. So the parents that have younger children, it's probably hard to relate, but having this clinic here with all of the doctors and therapists coordinated and having to come all day, I know it's a long, long day, but it is a lifesaver. And we are very, very fortunate to have it here in Phoenix. Number 2, I'm jealous. I'm jealous of what typical kids can do, right? We all feel that pang of jealousy every once in a while. Right now, Charlie at 15, most of the kids that we know at his age are getting their driver's permit. We're not getting our driver's permit. Charlie has missed most of the typical milestones in his life. However, he's met them. He has gotten there, and he will get there as long as it takes. After all of the years, though, it does hurt, and it probably always will. He just progresses slower than most kids, but he does progress. And he does get there. Recently, he told his teachers he felt he could do better on a reading evaluation as he approaches his sophomore year in the fall. And I was so proud because not only did he do that, and he advocated for himself, something that we've been really diligently working on, he doubled the score on that reading evaluation. It was almost as if he needed to decide, right, that he wanted to do better, instead of me pushing him to do better. Charlie, obviously, has always played baseball. He's been playing since he was about 5-ish. He was always the smallest guy out there, definitely not the fastest. And this year, he unfortunately didn't make the high school freshman team, but the coach asked him to help manage the team. He was embraced by the team and all the coaches, and Tuesday night, he received an award for Most Inspirational Player. I may be jealous of other 15-year-old kiddos, but my kid is rocking his own milestones in his own time. And I have to squeeze in there, I am a little jealous of other genetic conditions that get a lot of attention, a lot of publicity. I don't know about any of you, but I've had to explain what 22q and 1.2 DS is many times. I see a lot of nodding. All I know is by supporting the 22 community and spreading that awareness and explaining it over and over again, it just means more understanding of my kid. So it's important. Okay, number 3. I feel alone. When we first received diagnosis back in 2006, like I mentioned before, it felt like we had to figure everything out on our own. I didn't meet another family with 22q, with a 22q kiddo, until I went to a family conference in Texas almost a year later. It was there that I met Jenny, who's not here today, but whose son Lucas was just a year younger than Charlie, and she lived 2 miles from my house. And I had to meet her in Texas. Speed up today, I've met hundreds of families, and I get to meet you in person every month here at the clinic, and I've met amazing moms over many coffees who are now friends. We are over 120 strong here just in Arizona, and if you didn't know, next month, moms from all over the country will be connecting here in Carefree for a 22Q Moms Retreat, and I hope I see all the moms here there next month. Number 4, I'm scared. I'm scared of what lies ahead, of what Charlie's young adult and adult life will bring. But I've also been taught by Charlie to just simply take things as they come. You can't worry about something that hasn't happened yet. One of Charlie's biggest issues is communication. He misunderstands a lot, not just what happens around him, but he's also misunderstood himself. But I also know that any adult who has ever been fortunate enough to really know Charlie literally uses the word endearing. We've been hearing that word about him since he was a toddler. His sweetness and charm, we're hoping, just might carry him through. Another great quality is his supreme knowledge and interest in sports, in the video gaming industry, and amusement parks. You know, it's good because it's actually stuff other kids his age just might be interested in. And he's quite an expert. His knowledge is quite astounding. So we take the good and hope for the best and hope it pulls him through so it's a little less scary. Number 5, I wish you would stop saying, and this of course is going to the general public out there, that I hear a lot, oh, he seems fine. And he is fine, right? He's fine. Of course he is. He's doing great. But, there's a lot of stuff going on behind the scenes, right? And a lot of what Charlie faces, it's invisible disabilities. And a lot of people don't see what's going on. And so it's hard. It makes it a little bit of a struggle, kind of diminishes what we're kind of going through. I came up with a new word. I think it's a new word. I'm not actually sure. But I came up with boasting posting. So we're all living in this social media world, right? And a lot of us, even me included, usually just post all the good stuff, right? All of the accomplishments, all of the great things in our lives, right? And it's hard to hear about typical kids and all the things that they're able to do, right? And I just want to put out there that let's celebrate a kid's kindness, maybe a funny story, versus a kid's capabilities. The good news is our neighborhood up in Moon Valley, it's a safe place for Charlie. Our neighbors truly embrace him. He feels a belonging, and we've been very lucky to keep him at our home schools. It's not utopia. There's lots of overachievers in our neighborhood, but some of these very famous families are sincere in their desire for us to be included, and they love Charlie. I love this one. Special needs mom, only because multitasking ninja is not an actual job title. Number 6 is I'm human. I do often feel that parents of special needs kids are too often described as superhuman parents, right? We do more, we love more, we care more, we have more patience, we have extreme energy, we never get tired. But are we really? I think, are any of these attributes really true? I think us as parents, we're all, again, just doing the best that we can, like any parent. And the truth is, 22q can happen to anyone, anywhere, and we all just simply parent our kids the best we can and love them. This is another good one. Special needs parenting, some days it's like looking both ways to cross the street. You've done everything to prepare, and then boom, you get hit by an airplane. Number 7, I want to talk about my son, but it's hard to talk about my son. Again, ask me any chair question, easy. Ask me to talk about Charlie, it can be hard. That's why it took 4 years, Dr. Grebe. So usually it's just overwhelming. I don't know where to begin or how to talk about it. His accomplishments are small, right, to most people. They take longer. We were just talking about that with another parent this morning. And it's, again, not always visible to other people. And I'm extremely private. Usually when people ask me how we're doing, everything is fine, right? We're good. Everything's good. But, of course, we struggle. We hit tough road patches just like everyone else. And I just know this. Having the 22 community around me is comforting. So everybody's always asking me, like, why do you come to the lunches every month? And how do you do this? I'm not going to lie. It's self-serving. I do it because it makes me feel good, makes me feel like I'm part of a community, and that there's this blanket of understanding with all of you that we are going through this together. Thank you. So, of course, being the person I am, I wanted to share a couple other things with you. I wanted to share some of the Arizona resources. So I put a big old list on here. I probably could have done 4 pages on the PowerPoint of all of the resources, but these are just resources here in Arizona. If anybody ever has any questions about any of these resources, of course, ask. And then I also wanted to mention things that are happening now, other than Prince Harry and Meghan's wedding that's happening, I think. Oh, it's over? It's over? Tomorrow, all over the world, there's 22Q at the zoo, all over the world. As we all know, most of us, it's just too hot. We can't do it here in May. So we've done it in April before. Last year, we did it on a beautiful Saturday in October. And I hope we do it again this year. If anybody would like to help me with coordinating that 22Q at the zoo late, please let me know. Of course, I mentioned the Moms Retreat in Carefree next month. Who's going? Anybody here going? Oh, you need to get with me after this. And then in July, the 11th Biennial International 22Q Conference is happening in Canada, Whistler, which sounds really nice to be in Canada in July versus here. And that's it. Thank you so much.
Thank you, Kelly. That was amazing, and I think we all know exactly where she's coming from. I think we can all relate, and I couldn't have said it better. And I can also attest to the fact that Charlie is a wonderful young man. I get to see him once in a while, not often enough. Too many. Okay. All right. Let's see. Gives me great pleasure next to introduce Dr. Devinder Singh, another great partner of mine, who serves as our division chief in plastic surgery here at Phoenix Children's Hospital. Dr. Singh opened her clinical practice in Phoenix in 2006. Time flies. After 3 years of practice at Children's Hospital of Philadelphia, where I will say they have had the very first 22q clinic, but I think ours is better now. Definitely. Dr. Singh was also a faculty there at the University of Pennsylvania. She received her Bachelor of Arts degree from Yale University and her medical degree from Columbia University College of Physicians and Surgeons, and then did her postgraduate training first in general surgery at Columbia and in plastic surgery at the University of Pennsylvania. But she did not have enough education, went on then to complete further training, a very specialized fellowship in craniofacial surgery at the Children's Hospital of Philadelphia and University of Pennsylvania. And while she was there, she had advanced training in the management of cleft lip and palate, which is what we appreciate for our 22q clinic. She also treats craniosynostosis, facial and jaw anomalies, craniomaxillofacial trauma, which is a hard one, hemifacial microsomia, microcrotia, and I could go on and on about all the different types of conditions she treats. And she also had additional training in orthognathic, jaw surgery, distraction, osteogenesis of the facial skeleton, so she treats patients with small jaws, many different types of conditions. She's a faculty member at multiple medical schools, Mayo Clinic, U of A, and multiple societies. She does extensive research, clinical, and has published in the areas of craniosynostosis, pediatric cranioplasty, congenital mandibular hypoplasia, nasal reconstruction, and many other conditions. So as you can see, she's more than qualified to speak to you today about craniofacial manifestations of 22q, and I'm just thrilled to have her on our team. So, Dr. Singh. All right.
I was expecting a much shorter introduction, Terry. That's why I walked up here. I think Kelly's talk is a really hard act to follow, and I feel like Kelly really summed up how we feel as a medical community with 22q. I think she did a fantastic job of presenting the parents' perspective, and I think we as providers all know that it's very different than the perspective we have. And I almost started crying when Kelly was speaking. Because I get very emotional when I hear parents talk about their children. But we as providers have to take a step back and let go of our emotions to some extent to be able to care for our children. And I see a lot of familiar faces here, many familiar faces that I have not seen in my office in many years. It's really fun to run into kids. I've run into many of my patients with 22q at Target, at Trader Joe's, at PCH during the Christmas tree ceremonies. So to me, that is the greatest joy, is really when I see my patients outside of the hospital living life. And I really try to minimize appointments because I know that you guys are all burdened with appointments. It's not just me, it's everywhere and everything, and it's every minute of life. And so it's not that I don't want to see my patients, it's just that I'd rather see you guys at Target or Trader Joe's. So I want to thank Dr. Grebe. She has single-handedly really organized our 22q team and clinic and organized this symposium. She gives us all credit, but really the credit is all due to her. So Terry, thank you very much. I want to also thank all of you for coming today, for giving up your Saturday morning, arranging childcare, which is not easy, and giving us the privilege to speak before you all. So with that, I'm going to start. Craniofacial manifestations of 22q. I want to first acknowledge our other team members who unfortunately could not be here today. Patricia Beals, who's our cleft and craniofacial orthodontist on our 22q team, and also at the Barrow Cleft and Craniofacial Center, as well as Jessica Williams, who's our speech and language specialist with our team. And they both contributed to this presentation today. So the major craniofacial manifestations are really speech differences in dental and orthodontic findings, and I'll be touching upon both. Expressive language delay, as you know, is very prevalent in our children and patients, and 70% of them are still nonverbal at 2 years of age. I've had a number of patients who receive their first diagnosis because of this speech and language delay, and they present to my clinic with speech differences, and then they get genetic testing. And these are children who don't have other significant medical issues which have prompted them into the medical system prior to this time point. Articulation disorders are quite prevalent, not just in early childhood, but they carry on into teenage years and adulthood. Voice disorders such as hoarseness, the pitch of the voice, reduced loudness. Many parents say, my child speaks so softly, and this is all related to anatomic reasons. And then less common or motor speech disorders such as dysarthria or cranial nerve anomalies. The focus of this talk in regards to speech difference is going to be on velopharyngeal insufficiency, also known as VPI or VPD. This is probably the most prevalent speech difference in our children, with 75 to 90% of patients having VPI, and this results in a nasal voice. Oftentimes it can be quite severe, resulting in a very difficult time for strangers to be able to understand the child. A minority of patients actually have an anatomic anomaly with their palate, such as a cleft palate or submucous cleft, as seen in this child with a bifid uvula. And these are oftentimes picked up earlier than a child that has a palate that otherwise appears to be intact. So what is VPI? Why are patients with 22q affected? How do we diagnose and treat it? And what are the outcomes of surgery? These are the critical questions we need to ask when we think about a child with a speech difference. And do we do surgery? Do we not do surgery? How do we target it? How long is it going to take? When is speech therapy going to be over? When can I not have to worry about communication and speech? And those are the questions I'm going to touch upon today. So the anatomy of the velopharynx, I'm not going to get into too much detail, but it's essentially an open valve between the little uvula that hangs in the back of your throat, or the back end of your palate and the back of the throat. And essentially the palate needs to lift and elevate and close to the back of the throat in order to prevent air from escaping when we speak and liquids from escaping when we eat. So it affects feeding early on. Children, babies have a lot of nasal regurgitation, reflux, and this is constant. There's suctioning, there's gagging, and it's a struggle for babies. But then as we get into years of communication and adulthood, this continues to have an impact on how our patients communicate. It also impacts resonance and articulation, which is pronouncing of the words. So this is just what I was talking about, the closure of the valve. It's really the musculature that pulls back and closes our palate off from the nose. So this is a few depictions of a cleft palate. The child on the picture on the very bottom has a child with a complete cleft palate, which is picked up early on. But the ones that are more subtle, such as submucous cleft palate, and the picture on your far left has what's called a zona pellucidum, that dark line in the middle that shows that the muscles are separated. These findings often require early intervention. A cleft palate is typically repaired before 18 months of age. However, submucous cleft palate, we frequently wait to see if the child actually is symptomatic from a speech standpoint. So VPI occurs when the soft palate doesn't fully contact the back of the throat, and that oftentimes that back of the throat is the adenoid pad. For each patient, it occurs at a different level. And the only sounds in the English language that require us to have any degree of nasality are M, N, and ing. All other sounds in the English language require closure. So we have an awful language in this country to have kids who have hypernasal speech or VPI to be able to really clearly say sounds without producing hypernasality, whereas many languages internationally require a fair amount of nasal air escape, and children are often better understood in those languages and some of our kids who are bilingual. So what the classic findings of VPI or VPD or hypernasality, and our speech specialists are really great at mimicking the sound, but instead of being able to say shoo, children will say shoo. So a lot of air escape comes through the nose. There's oftentimes audible nasal air emission, weak pressure with consonants, so that leads to the soft spokenness of our patients. And then compensatory articulation errors. So children try to work around the palate anatomy to make the sounds. They really want to communicate, not just with their parents, but also with their peer group. And so glottal stops happen where consonants are missed. And patients are learning to bypass their palate and use other mechanisms to be able to communicate. So in order for us to diagnose VPI or VPD, we need to have enough language development so we can actually get a reliable speech evaluation. And in our patients with 22q, this oftentimes happens at 4 to 5 years of age. To me, that's typically when children who have not been diagnosed at birth then present to us, when they really have some speech and language delays, some developmental delays, and then the speech difference evolves. Video fluoroscopy is done at some centers, but we really do the focus on nasopharyngoscopy or nasoendoscopy here at our center. We find that it's reliable, it's well tolerated by most children, though parents will disagree with that. It's a very small camera that's inserted into the nose that videotapes the soft palate and the pharynx while children speak. And this is a depiction of it, and this on your far upper right is the velopharyngeal port at rest. Let me see if I can get this laser pointer to work. So this is the adenoid bed, and this is the palate, and this is the opening which we require to be able to breathe through our nose. And then when we speak, this is all supposed to close, not just the palate to the back, but the lateral walls are supposed to move in. This is a patient during speech that continues to have a gap in the middle, and this is what causes the nasality. The goal of doing this evaluation is to assess where this gap happens and what the size of the gap is, because this helps us decide on which surgeries to perform. And then it also helps us to determine each individual's movement pattern. It's not the same surgery and the same movement pattern from patient to patient. Why do our patients have VPI? In 22q, it's multifactorial. Cleft palate, submucous cleft palate, it's obvious. The muscles are separated. The palate's not working. But the vast majority of patients, it's related to weak neuromuscular ability. So the palate is hypodynamic. It doesn't move with the same amount of strength that it needs to move with. And it's not just the palate, it's the entire pharynx, the lateral walls, the posterior walls. Everything moves together like a sphincter to tighten and close that area. Adenoid and tonsil hypoplasia can contribute. And then the least understood or the least talked about is that patients with 22q also have a different anatomy to their skull base, so it makes their throat much deeper and wider. So whereas our skull base is at this angle, patients with 22q have a much broader angle, and therefore that leads to a deeper throat and a greater distance at which the palate has to move. And this is the depiction of the difference in the skull base. So this is what's considered an average skull base angle, and you can see it's increased. So by increasing it, the palate actually has to move further. Even if the palate is intact, for it to be able to reach all the way to the back is very challenging. So what are the treatment options? There are appliances. These are not well tolerated, not by children, not by teenagers, not by adults. A lot of patients gag, having to take them in and out. And families always want to know about non-surgical treatment options, and we have not found one that is actually well tolerated. So surgical management remains the standard of care for treatment of VPI. And I'm not going to lie to you, and I think all of you have been there with children, that it is more difficult to treat in patients with 22q. Outcomes are less favorable than in children who just have an isolated cleft palate and don't have the diagnosis of 22q. And rates of revision are higher. Patients undergo one surgery, we get some improvement or no improvement, and then we have to regroup and we have to reevaluate. And part of that is that we're treating a growing patient. We're not treating a static patient, so we may do surgery and get through speech therapy, and then at age 6, 7, they're great. But then through their teenage years, they go through puberty, and there's growth, there's change of the skull base, there's change of the upper jaw, the distance from the back of the throat, and we have to regroup and say, okay, what are our needs now? Do we need to do more surgery? Can we treat this with speech therapy? Where are we? So surgery really needs to be individualized because I had said earlier, each patient's anatomy is different, each patient's movement of their palate is different. Considerations prior to performing surgery, the nasoendoscopy we spoke about, size of tonsils and adenoids. If we're planning surgery, we really need to make sure that we don't cause more problems for our patients, and therefore we're looking at the size of the tonsils and the adenoids to see if we need to do that surgery prior to doing any secondary speech surgery. History of sleep apnea, because our patients have oftentimes low tone, that low tone translates into oromotor control, low tone in the airway, and many of our patients have sleep apnea. So if we have a history of sleep apnea, we have to be on high alert for potentially worsening this with the speech surgery. And the reason is because we're making it harder for patients to actually breathe through their nose with the speech surgery. Carotid artery positioning is another critical thing. 20 to 25% of children, of patients with 22q, the internal carotid is shifted medially. So typically they sit kind of in this portion of the neck, and they can be shifted into the middle. And this is not important on a day-to-day basis for our children, but it's very important when I'm lifting the pharyngeal flap off the carotid artery to inset it. I don't want to damage the carotid artery. And C-spine anomalies, any instability. Some of our patients, we have to position the neck a certain way, and that's something that needs to be evaluated prior to surgery. And other associated medical conditions, Dr. Pofall will talk all about the cardiac conditions, of which I have minimal knowledge, but something that I really focus on when we're planning surgical treatment for our children. And then the psychological assessment. When do we operate? So we know our child has speech difference. They've been evaluated. When is the right time to operate? Age 4, age 5, age 6, age 13, age 15? I think that part of it is the readiness, the awareness of speech and language, and the awareness of communication, and the self-correction. I was talking to one of our moms earlier today, and I said, it's a non-stop involvement on the parts of families to correct speech. And if a child doesn't have that awareness, it's even more challenging. And I think that in those situations, the surgical timing should really be considered, because without post-surgical speech therapy and an awareness on the child's part, we put all the risks of surgery on the child without any of the benefits. And so some of our patients do undergo surgery for VPI, VPD at an older age, sometimes in their teenage years, and not when they're 4, 5, or 6 years of age. So what are our surgical treatment options? And I'm not going to focus too long on this, just a few slides. Palatoplasty, this is done when the child is young and you see an obvious cleft palate there. This is just the technique I use to lengthen the palate and also to reorient the muscles. But we know that it's very uncommon that a palate repair alone in infancy is going to be sufficient for our children, and it's primarily because the throat is so deep. And our children often go on to young adulthood, teenage years, requiring secondary speech surgery. So these are the two workhorses of speech surgery. One is called a sphincter pharyngoplasty. So it essentially converts a large central port where we're breathing through our nose into a smaller, tighter port so that the palate has a smaller distance to move. This is utilized when the palate appears to be long enough, but the lateral walls don't move at all. And this anatomy and this movement pattern is determined based on the scope that's done prior to surgery. The more commonly used procedure, because most of our patients have a very long reach from where the palate ends to where the back of the throat is the posterior pharyngeal flap. And so I'd say most of our patients have undergone posterior pharyngeal flap. I probably have a handful of children in which I have done both surgeries, where we do the posterior pharyngeal flap and then we don't have enough improvement and we need to come back and do the sphincter pharyngoplasty. We can't do it in the reverse. We can't do the sphincter first and then do the posterior pharyngeal flap, because we cut off the blood flow to the posterior pharyngeal flap. So if there's a need for both, because the gap is so large, they need to be done in a specific order. And this is where the pharyngeal flap sits. So when you look in somebody's mouth, you don't actually see something that's hanging out there. Many parents are like, I don't see anything. What happened? What did you do? Well, it's hidden. It's hidden up in the back. It needs to sit. Here's the little uvula portion of the palate. And the pharyngeal flap really needs to sit up here where the palate closes when we speak. This is just a depiction of the carotid artery medialization, and you can see that here's the airway, this is the posterior pharynx, and this is where the flap is elevated. So typically they're quite lateral. However, in patients where they're medialized, I have to be careful in terms of dissecting the pharyngeal flap off. It's very thin tissue directly over the carotid fascia. So surgical outcomes. We do very rigorous speech assessment with nasometry and full speech and language evaluation at 2 months, 6 months, and 12 months post-surgery. Much of the literature shows that it takes 6 to 12 months for that flap to fully heal, for patients to adjust to the change in anatomy, and for the ultimate speech outcome to be realized. All patients during this first year post-surgery benefit from ongoing speech therapy because of all the compensatory speech that has developed because the palate didn't work well for them. What are our speech outcomes? Parents say, well, is this going to fix the speech difference? Is my child going to be able to be understood by other kids and by their teachers? If the hypernasality is mild prior to surgery, post-surgery, we expect a complete resolution of the hypernasality. If it's moderate, the vast majority of patients who undergo speech surgery will achieve normal resonance. However, if the pre-surgical hypernasality is severe, less than half of our patients achieve normal resonance. All have some improvement, but most then desire further speech surgery, like a second speech surgery, to try to get that communication to a level where it's not a daily struggle or a daily challenge. Sleep apnea is probably my biggest fear. I don't try to scare our patients, but it's something that I'm very thoughtful of moving into surgery, especially secondary surgery. If families give us a history of sleep apnea prior to surgery, we do get a sleep study. Many of your children have probably gone through sleep studies, and it's not easy. You're going to a foreign environment, disrupting life, and so they can oftentimes be challenging to get a reliable sleep study. Pre-surgical tonsillectomy and partial adenoidectomy in hopes of preventing development of sleep apnea. So the tonsils, as you know, sit on the side when you put a pharyngeal flap up in the middle to block the air. Those tonsils need to be gone in order to be able to breathe through the sides so that we don't have that risk of sleep apnea. And then post-surgical monitoring. For the first 2 to 3 months, we know that our children are going to snore. Our patients, at whatever age they have the surgery, are going to snore, and they do have mild sleep apnea. But this, if it doesn't resolve by 3 to 4 months of post-surgically, we then get another sleep study to see where we are. And then it becomes this finding this balance for each patient. Where do we maintain correction of speech but improve their sleep apnea? And the risk of sleep apnea is the greatest in our patients with 22q because of the tone of the airway and the innervation of the muscles of not just the palate but the lateral walls. Some of the speech concerns that carry on beyond addressing the nasality component of it is articulation. Some of our teenagers and adults with 22q present with continued articulation challenges, and that's the sound. It's how we pronounce words. If these errors are present, we continue speech therapy. So as much as we would like to hope that we have pre-surgery speech therapy, we get our secondary speech surgery done and then have post-surgical speech therapy and then we're done, it really becomes a lifetime of speech therapy, but not continuous. It comes in certain distinct periods when patients experience challenges in communication. So what is resonance versus articulation? Because I think it's important to understand this. We have a number of children who been treated for 2 to 3 years, many years by speech therapists who are not fully aware of what 22q is and fully aware of VPI, and they target the things that are not really needing to be focused upon at that age range, and I think that it burns children out from speech therapy. It causes delays in actually addressing the problem. So resonance, which is the hypernasality or the VPI, can only really be addressed through surgical management, and ongoing speech therapy only frustrates the patient. If you don't have the anatomy to produce the sounds, asking our patients to produce the sounds is not fair to them. And that's where we really need to do an evaluation in terms of planning out the speech program or treatment plan. And we work closely with our speech and language specialist, as well as the individual and the family and the school situation, our speech pathologist at school, in developing not only speech therapy at the outpatient setting, but also in the school setting. Articulation is addressed through speech therapy. Surgery is not going to help articulation. It's not going to correct the tongue placement for the sounds or speech errors. And some of those are compensatory because we haven't given the patient the ability to speak from the palate level. They've learned these compensatory errors, and with speech therapy, those will be corrected. The other component of language, which really affects more young teenagers and adults, is pragmatic language. So some individuals have difficulty with social language, and it typically manifests itself in the preteen, teenage years, and it's topic maintenance. How do you continue a conversation? How do you have that back and forth? How do you socially greet another teenager? And I don't even know how to do that, but apparently they have their own language. How do you understand when another teenager is making a joke, or like colloquial language? How do you read emotions on other teenagers and adults' faces? And I think that, you know, some adults, 22q or not, are challenged, but I think that our patients with 22q, this is a more common theme. And, you know, Terry, in addition to organizing this, also helps organize the summer speech camp for our 22q patients. And the focus is not on really teaching them articulation skills within a week, but the focus really is on being able to socialize, learning that engagement, learning how to carry on a conversation. And I think that this pragmatic language is, in the teenage and adult years, even more important than the articulation or a little bit of nasality, because we all have different speech patterns and different sounds to our speech. So a little mild hypernasality, a lot of people have it. It's really the ability to communicate, and communicate on a level where you feel like you're engaging with other humans. So not only do our speech therapists focus on the nuances of the speech, but also on pragmatic language, and work on developing a home program and a school program for our patients. And with this, I'm going to turn over to the dental and orthodontic manifestations, and I'll try to go through this a little bit more quickly, and I'm open to questions at the end when Dr. Pofall has given his portion of the program. So general tooth anomalies, as many of you know, are quite common. 65 to 75% of our children and patients have them, and this is a lifetime concern and a lifetime focus, especially if there's an innate weakness in the teeth. So the most common is enamel irregularities, weak enamel. There's a moderate to very high rate of decay, despite all the brushing and despite all the flossing and despite the parents doing it well into the teenage years. This is just the anatomy, and many of our dentists are not aware of that. And so we really want to educate our families so that we can promote prevention. Once the decay happens, it's discouraging. It's discouraging to parents. It's discouraging to children. They become then disinterested in even maintaining oral hygiene because they're just so frustrated. So I think knowing this very early on, and by early on I mean in infancy, children start developing teeth between 8 to 9 months of age, some earlier, some a little later. Dental crowding, spacing, delayed eruption of permanent teeth, missing teeth, poor oral hygiene, these are all common things that we deal with, and then malocclusion is from the orthodontic component that I'll touch upon. So what happens with the enamel? It can be hypoplastic. That's the most common finding. And that's a genetic disturbance in the formation of the enamel matrix. It's nothing that's done. It's not the kind of milk or formula that's given to the child early on. And then hypocalcification. And we all see, I mean, oftentimes patients think, or dentists think, oh, this is a cavity. Well, this isn't a cavity. It's just hypoplastic enamel. So the brown staining, the weakness, the crevices in the teeth. The decay occurs because of the enamel irregularities, but also because of childhood illness, nutritional supplements. Many of our children have failure to thrive, feeding difficulties, so we're giving them Pediasure. Some of our teenagers are still on Pediasure to supplement for weight gain. All of these nutritional supplements have so much sugar in them, and this constant sipping and drinking of sugar supplemented drinks causes decay to progress. Our patients also have decreased saliva, and this decreases the coating and the protection of the teeth. Hypoparathyroidism, medications that dry the mouth, and then oral aversion. There are a lot of sensory issues. Kids don't want their teeth brushed. They don't want someone examining their teeth. And when you have to do it twice a day, it's easy to say, okay, well, it's late, we'll do it in the morning. But it's just constant, it's a constant struggle sometimes for our patients. The orthodontic findings primarily are with an open bite in the front, and this starts developing in early childhood. High arched palate is frequently seen, though doesn't really cause any problems. It's really the way the teeth fit together. Possible causes of this are what we had talked about, the obtuse cranial base angle, low muscle tone, and because our children have a lot of sensory issues and also have reflux, thumb sucking, pacifier usage is common in our patients, and this contributes to the malocclusion that we see in the teenage years. And so this is the same photo just showing that, so if this is the angle at which we live, and then our patients have an obtuse, it flips the front portion of the jaw up, resulting in the anterior open bite. And here's a patient who has the classic anterior open bite. So if you look in the back, the teeth seem to fit together well, but this upper portion is forward. And this causes not only problems with biting into food, but articulation, tongue placement during speech, and then just socially. Drooling happens. Tone, closing of the lips while they're chewing and speaking is very challenging, and they have strain on the muscles. And so then that causes problems during social eating and conversation. Thumb habit can contribute to this. So this is a child prior to developing the obtuse angle contribution, and this is really from thumb sucking that can cause an anterior open bite. And so we really encourage families by age 3 to try to get rid of the pacifier, to try to break the thumb sucking habit. So it's really a combination of causes, and most of these can be treated orthodontically, but I think the challenge is when a patient has an innate growth pattern of developing the open bite, but then also has had prolonged use of thumb sucking or pacifier usage, and that's when then oftentimes jaw surgery is needed, and we can't just correct this orthodontically. So prevention is key. I'm going to just quickly review over important things that you guys need to know about prevention. Fluoride is critical. You can buy over-the-counter oral rinse fluoride, and this is lifelong, right? Even into teenage and adult years. There's systemic fluoride that's important, and your dentist can monitor that, making sure there's enough fluoride in the water that gets into the system to help with the metabolism of the teeth. But then also an oral rinse that coats the teeth. We really encourage connecting with a pediatric dentist at age 1, and then instead of going just twice a year, they really need to be going every 3 months to have checkups and checking for decay, because the earlier we catch them, the more we can treat them and prevent progression. Typically, primary teeth don't have sealants put on them. We encourage sealants be placed on primary dentition for our patients with 22Q, as well as on the permanent teeth. Brushing and flossing, limiting sugar drinks, apple juice, Pedialyte, Pediasure. Sipping sugar drinks during the day is the worst thing, as opposed to drinking a Pediasure at lunch and then not having any sugar for 3 to 4 hours. And the reason is because every time we sip a sugar drink, the pH in our mouth changes, and that changes the bacterial balance, and then that changes the plaque formation, and it changes decay levels. Check medications for dry mouth. Those patients who are on medications for dry mouth, they need to get mouth rinses that increase the saliva. Sugar-free gum increases saliva, so that is actually good for patients to use. And then orthodontic consultation at age 7. In speaking with Dr. Beals, she said that with our children with 22q, typically a lot of patients go through phase 1 orthodontics and then phase 2. Because of oral aversion and because of all the other medical needs, we really try to do just one phase of orthodontics with our patients with 22q, and that happens during their preteen and teenage years. Really, you want to minimize decay on the teeth. Having braces on twice decreases the ability to clean the teeth and maintain hygiene. So to just summarize back to speech, VPI is best managed with surgery, though we cannot manage it without our speech and language specialist. We really have to evaluate thoroughly and individualize surgery. The posterior pharyngeal flap is preferred, though the surgery is really tailored to each patient's anatomy. Our outcomes are more variable in our patients with 22q, and it really carries into teenage and adulthood years that we're monitoring speech. From a dental and orthodontic perspective, we know that our patients have dental anomalies. We have to educate our dentists. We have to be advocates for our children and our patients. Early prevention and timely intervention are key. And just to remember, just because the baby teeth have weak enamel and you have a lot of problems in childhood, it does not mean that the teenage years are going to be ongoing challenges. The adult dentition can have normal enamel and not be so easily prone to decay, but the oral hygiene component is still critical during those years, especially as orthodontic treatment is being initiated. I'm going to end with that. I hope I didn't run over time. Carrie, thank you.
Thank you, Dr. Singh. That was wonderfully comprehensive, but I'm sure many of you will have some great questions for her. I know I introduced her as speaking regarding craniofacial manifestations, that mainly from a plastic surgery perspective, but as you can see, you got 3 talks in one. She spoke about speech issues as well as dental and orthodontic. Okay, so I know we're running a little behind, so we're going to hold questions until after our next speaker, and I'm now thrilled to introduce my other 22q partner, Dr. Stephen Pofall, who is a cardiologist here at Phoenix Children's Hospital. I've had the great pleasure of working with him for many years. Prior to coming to Phoenix Children's Hospital, he was at the University of Chicago, and I know he worked in a 22q clinic there, so he has extensive experience, more than I do. Dr. Pofall received his undergraduate degree in mechanical engineering, go Engineers, from the University of Notre Dame, and his medical degree from the Ohio State University College of Medicine. He completed his pediatric residency at the University of Chicago and a fellowship in pediatric cardiology at the Children's Hospital of Pittsburgh. He was then an assistant professor in pediatric cardiology at Rush Presbyterian St. Luke's and Northwestern Feinberg School of Medicine in Chicago. So that was his former life, and he's been in Phoenix for quite a while, I think, as long as I have. He has served and worn many hats here at Phoenix Children's. I had to kind of pull him into full-time 22q work almost, but prior to that, he was director of our pediatric heart transplant program and is still very active in that. Director of heart failure and cardiomyopathy services he also did previously at Northwestern. You know, he's very busy in the cath lab, so I'm typically calling him there as well. But he helps me with our clinic, and for those of you who come, the mornings are spent in the Heart Center with us, and Dr. Pofall is there helping guide us through. So it gives me great pleasure to introduce him to speak to you about cardiac manifestations of 22q.
Thank you, Terry. It's a great morning, and I'm going to try to catch up so that we are respectful of your time. Thank you all for coming. This is a phenomenal presentation. I'm going to try to get us caught up in the sense of cardiac manifestations of 22q, and I think I'm not going to go into great detail about the cardiac manifestations, but more importantly, look at the hope for the future and the transition for success. And so I'm giving you some anatomy lesson, but I'm not going to dive into it in great detail, and it's in your binders, for more details. So if your 22q family member has one particular defect, you'll have more and more details in that binder as a reference. Oh yeah. So what I'm going to really gear towards is the anatomy, and then what the follow-up is key to. This table's actually very interesting in the sense of the incidence of congenital heart disease or having a heart abnormality is essentially 1 in 100, in somebody who doesn't have 22q. But if you have a chromosomal aberration, it's about 80%, so 8 out of 10. So your odds go up tremendously when you have 22q. So many of the manifestations of 22q are heart-related. And the conotruncal, that's going to be the word of today's speech, conotruncal, is really in an area that I'll show you on some of these anatomy slides. And I hope to get us caught up so that you can take a break and go outside and see some of these 3D models, because it'll actually show you what these conotruncal abnormalities are. And essentially it's in the middle of the heart, and I'm going to go over this in a little bit more detail through some of our anatomy slides. But in the population, 1 out of 100 has a congenital heart disease, but 50% of them have conotruncal abnormalities. In 22q, 80% of patients have heart problems, and 90% have conotruncal abnormalities. And so these conotruncal abnormalities occur at the top of the chest. So it's almost from your breasts up that you have abnormalities when you have 22q abnormalities, whereas when it comes to the general incidence of congenital heart disease, it's all over your chest. So it's very fascinating. And actually we're doing some deep gene analysis to try to figure out why that's happening. The 22q is the second most common genetic cause of congenital heart disease. Trisomy 21 is the first. It significantly affects the prognosis and long-term follow-up of patients who have this. So if your family member has heart problems, you're seeing the specialist more frequently, essentially. Full evaluations occur, and for a lifetime, you usually have follow-up with your congenital heart specialist, depending upon the severity of the disease. This is a very, very busy slide, and I'm not going to go through this at all, to tell you the truth. But it's in your binder, and essentially it goes over the conotruncal abnormalities, tetralogy of Fallot, truncus arteriosus, double outlet right ventricle, and essentially interrupted aortic arch are some of the things I'm going to show you in some of these slides, and I'm going to focus on the anatomy in the middle of the heart and the top of the heart. But by and large, 80% of the congenital heart disease are that area, the key sweet spot of conotruncal. How do we figure out if somebody has 22q? Most of the time, the fetal echo will show some abnormality in this conotruncal area. The cono is the area where it closes the middle of the whole of the heart, all right? And every mom who has a prenatal ultrasound gets a 4-chamber view of the baby's heart. And if there's a hole in the middle, that's a possible conotruncal abnormality. So prenatal diagnosis many times gives us a hint that somebody has 22q abnormalities. Tetralogy flow is the most common conotruncal abnormality and the most common reason a baby is blue. Every single baby who's born gets a Band-Aid on their finger to check out their pulse oximetry. You want to get an A+. 95 or 100%. If you have a B or a C, that means you're not getting enough oxygen to your body, and you may fail that test because there's the blue baby syndrome. And that is very common in 22q, where there's some hole in the heart and some narrowing somewhere leading to the blue baby syndrome. And tetralogy of Fallot is the most common blue baby syndrome. This is the anatomy lesson. So in the normal physiology, blue blood easily makes it to the upper chambers, lower chambers, out a beautiful valve to a normal-sized tube. And then it gets oxygenated, comes back as red blood, upper chamber, lower chamber, normal-sized tube. So in the mom who's getting screened, 4 chambers, 4 valves, 2 big tubes all look normal. In a conotruncal abnormality, this septum, or the wall at the lower chambers, is open, and the wall that was supposed to close the hole is either deviated towards the blue side or deviated towards the red side. And no flow, no grow. That's a common thing in congenital heart disease. So if you have no flow to the blue blood vessel or the pulmonary arteries don't grow. If you don't have good flow to the aorta doesn't grow. And so we can kind of predict which side of your heart's not going to grow because of inadequate flow. I'm not going to go through all of this presentation, but tetralogy of Fallot is very common for a baby to have spells, and these are blue spells. And the degree of the blue spells depends on that speed bump below the pulmonary artery. If the speed bump is really, really big, you're going to have a lot of those blue spells, and the surgeons need to fix that speed bump. The management depends on that speed bump, and the degree of blueness. So if somebody has a lot of blueness, they got to get the blueness to go away by getting rid of the speed bump, closing the hole, and reconstructing the pulmonary artery. And for transition of success, we're going to talk about what surgeries lead to what potential chronic problems and how we deal with it here at Phoenix Children's and across the world. The management is to, and I'm not going to go through all of this in great detail, but to secure blue blood to the lungs so it can get oxygenated so that your score is back to an A or an A+. And we want to have an oxygen score of about A+ so that you have good oxygen going to your brain. And this can be done in many different phases. The first phase for somebody who has severe blue spells in tetralogy of Fallot is to do, because there's not adequate blood going to the pulmonary artery, we bypass it with a plastic shunt. And this was developed back in the 1950s and 1960s and saved thousands of babies with tetralogy of Fallot. But prior to the 50s and 60s, almost everybody died with tetralogy of Fallot. The full repair is to get rid of that speed bump with a patch and to open up this area such that blue blood can make it to the pulmonary arteries. But it's not that easy by any means because there's a very delicate valve right in that area, and you need a good valve in order for blood to make it out to the lungs and stay out to the lungs. So that's the key to tetralogy of Fallot. The most severe form of tetralogy of Fallot, and I'm not going to go into this in great detail, I'm going to pass over this, is called pulmonary atresia. And pulmonary atresia is where you don't have a pulmonary valve at all. So that speed bump is so thick that you don't have any blood flow going out to the pulmonary arteries. And so how does blood actually make it to the pulmonary arteries? It's so complicated, but it's essentially a normal upper chamber, lower chamber, out a great valve to the pulmonary arteries. In pulmonary atresia, there's no blood going to that pulmonary arteries, so it goes through that hole, the conotruncal abnormality, out to the aorta, and it does a detour, like hundreds of canals going to the pulmonary arteries. And so instead of a tree with a big trunk and good branches, this has no trunk and lots of branches are all over the place. And this is very, very complicated repair for tetralogy of Fallot. And I'm going to show you a case of this that is really cool. I'm not going to go through all of the pulmonary atresia, but essentially you need to close the hole, reconstruct the trunk, put the branches together to try to make it better. And before you do that, these babies are so blue because they have such a big speed bump disallowing blue blood to the lungs that they need a medicine, an IV medicine, before they can actually leave the hospital to restore blue blood to the pulmonary arteries. This is actually showing what, and I'm going to show you a couple pictures of the actual conduit or right ventricular to pulmonary artery tube that needs to now be fashioned for patients with tetralogy of Fallot or pulmonary atresia. So if your pulmonary valve is so small, you need a different pulmonary valve. And that's key to the success of 22q patients with bad valves. And I'm going to go over this in a little bit more detail. So tetralogy of Fallot, pulmonary atresia, lots of little branches, no main trunk, reconstruct the trunk, and then try your best to make these branches bigger and bigger and bigger. And as a catheterization person, I got to go out into those branches and stretch them to make them bigger. Luke's story, I'm going to show you a 3D model of Luke's heart. Luke is a patient who was prenatally diagnosed with tetralogy of Fallot, and he was born over at St. Joseph's Hospital after having the diagnosis of tetralogy of Fallot. He had a CT scan at 1 day of life. His CT scan data was sent over to Phoenix Children's. We used our ASU Engineer Collaborative 3D Print Lab to print Luke's heart at 1 day of life, and we showed his heart to the entire cardiac team. This heart here is essentially the right ventricle and the pulmonary artery, very, very narrow in this pulmonary outflow tract, and everything that's blue is supposed to go to the blue side of the heart, and everything red is supposed to go to the red side of the heart, but anything that's green or yellow is abnormal, and those are those collaterals. The heart was utilized by the surgeons, the intensive care unit. The father came over here and was in tears because he could see that his son's heart was abnormal and that the whole team was actually examining the heart before he was even transferred over to the hospital for surgery. His mom came over with our nurse practitioner, and she had Luke's heart in her hand before Luke went to surgery, and the surgeons had the heart in the operating room, and they've already practiced on the heart before doing open heart surgery. And that's what leads to such great results here at Phoenix Children's Hospital, is that we have this technology to do 3D imaging and 3D printing before we do surgery. This is actually Luke's heart, spinning around here in a nice little table. These are these extra vessels going to the lungs that aren't supposed to be there. All these little green and yellows are not supposed to be there. And all the blue that is supposed to actually make it out there is too small. And so the surgeons make the tube bigger, and the catheterization guys embolize the things that aren't supposed to be there. Truncus arteriosus is very similar to tetralogy of Fallot, but it's almost in the extreme form, and it's a big problem because it has two valves that are abnormal. About a quarter of our patients to maybe 20% of our patients have truncus arteriosus, and this could be a big problem because the conus, which is the middle of the heart here, the muscle's missing, and then the truncus, which is essentially what's supposed to separate into the aorta and pulmonary artery, is all fused together. And the truncal valve can be abnormal. So not only do you not have a good pulmonary valve like tetralogy of Fallot, but now there may be a problem with the aortic valve, which is the most important valve in the body. And I bring it up because truncus is rare in the general population, but very common in 22q. And then the 22q patients may need, may need two valve surgeries instead of just one valve surgery if the truncal valve is stenotic, which means tight, or leaky. And this is a huge, huge deal. At least since 2005, 2010, there's been a much easier way of managing aortic valve and pulmonary valve disease without surgery. I'm by no means going to go over the surgical management of truncus arteriosus, but with a surgical repair, you have to open up the conal truncal area, close the hole in the heart, reconstruct the truncal valve, and put in a new tube. Some of these tubes are, and I'm going to go through this in a little bit, from donor patients. So those are called homografts. Some are from cow valves, and some are from pig valves. And these can all be utilized to reconstruct the key valves inside the heart. So the pulmonary valves and the aortic valves can be reconstructed with either cow, pig, or human donated valves. Now that's a big problem because those can be rejected and they don't grow. And in order to actually try to make them grow, we can take catheters up into the leg, across the valves, stretch them, or insert valves inside of these valves to actually make them better valves. And I'm going to show you this, and there's actually on the table on the break, there's catheters on the table, balloons, and valves and stents, just to kind of, please go out there and test them and see what they look like. But those actual valves we can put valves inside of those valves with the latest and greatest technology. This is a valve that the surgeon would actually put in, and this is actually a pig valve sewn inside of a ring, and that ring is then put into the pulmonary or aortic position, but it can reject, and it can get tight, it can get leaky, and then we can insert another valve inside of that valve. And the way that actually happens is that we pass a catheter through the leg, through the upper chambers, through the lower chambers, and through the catheter, there's a stent on a balloon. And then we inflate the balloon, and then that stent can actually open up, and inside of that stent is a valve. And so this avoids the teenage 20-year-old or 30-year-old second or third surgery for pulmonary atresia, tetralogy of Fallot, or truncus arteriosus. So the transition to success includes catheter-based valve insertion as opposed to surgical-based valve insertion. This is an angiogram on the cath lab where we have a wire sitting outside in the pulmonary arteries. We have this big stent inside of the pulmonary artery, and we're inflating this big balloon to inflate the valve that's on that stent. Big procedure, but has changed the landscape for aortic valve disease or pulmonary valve disease. In fact, many 60, 70, and 80-year-olds who have aortic valve disease are getting transcutaneous aortic valves right now, and there's a heart model out there of the transcutaneous aortic valves. Our 22q experience has been a little bit different in the sense that there may be a higher incidence of infection of patients who have a valve inserted, and it may be due to the thymic hypoplasia and the T cells that are developed that help fight against infection. And so our PCH experience over the past 5 years, we've implanted 80 valves. We've had 3 infections like the general population, but 2 of those 3 have been 22q patients. And so in our multidisciplinary clinic, we've worked very hard in order to identify which patients may have a higher risk of infection. And we attack that earlier with antibiotics. Interrupted aortic arch is another conotrunkal abnormality where the hole is big, but the speed bump is on the aortic side. So with no flow to the aorta doesn't grow. And it's supposed to be a big, nice candy cane of flow going to your upper body and lower body. But with interrupted aortic arch, there's no flow to the lower body, and these babies can be immensely sick because they have absence of flow to their bellies, absence of flow to their kidneys, and can be very sick. And these kids can present in, they call it extremis or shock, if they're not identified early on. Management is surgery, and that is sewing the aorta back together and closing the hole in the lower chambers of the heart. But that doesn't always work, and there could be some scar tissue in and around the aorta in this area. And so over the past 10, 20 years, we've developed balloons and stents to open up the aorta to make it look like a beautiful candy cane, and there's adequate flow going to the whole entire body. Now, the key to arch abnormalities is that about 20% of our patients with 22q can have aortic problems that aren't associated with problems inside of the heart. And those are vascular rings, slings, and other things, where the aorta, just like Dr. Singh had noted, where the carotids are not in the appropriate spot, the whole aorta can be twisted around the food pipe or the windpipe, and that's called an aortic ring or sling. And in a normal situation, the left aorta just goes around, and then the windpipe is here, and the food pipe is here, and it's staying out of their neighborhood. But in vascular ring or vascular sling, the aorta does a complete ring around the food pipe and the windpipe, and then that can lead to some severe feeding difficulties and breathing difficulties. And that can be as much as 20% of our patients who have vascular rings or slings. And this is 3D modeling of the airway and the food pipe, and we can actually see this in great detail and make a 3D model of the vascular rings so that the surgeons can actually practice on resecting the ring and relieving the obstruction to the food pipe and the windpipe, so that patients can breathe better and eat better. And we have many different models in the table back there of vascular rings and vascular pulmonary slings. Sorry about that. We've got some issues with this computer acting funny. There we go. This is an actual 3D model of the heart that we work with our ASU engineers, and we can move the heart around, and this is the right ventricle, left ventricle, this is the aorta, this is the food pipe here, this is the windpipe in white. So the white windpipe should have air going in and out of the windpipe without difficulties, and then the beige food pipe should not have any problems at all, but you can see that the food pipe doesn't even connect. So when trying to eat solids, you may not be able to eat solids because the red aorta is making a complete ring around the food pipe, and the food pipe is getting caught in the middle of that ring. So we show this to the surgeons so the surgeons know exactly how to resect the aorta safely to relieve the obstruction on the food pipe and the windpipe. And so seeing it better allows for us to fix it better with 3D modeling and 3D printing here at Phoenix Children's Hospital. Food pipe, windpipe, vascular ring. 22q patients with congenital heart disease need significant communication between all the subspecialists. In the Heart Center, we have intensive care doctors, we have surgeons, we have cardiologists, but more importantly, we need the entire team here at Phoenix Children's Hospital to take care of these very frail babies. And these very frail babies are going to turn into, big, rambunctious teenagers and very successful adults with no congenital heart disease, as long as we go through the protocols of making sure that we identify the heart disease, treat it appropriately, and then monitor it carefully over time. And all of this is in your booklet, but I'm going to try and catch up a little bit so that we can go to the long-term follow-up for congenital heart disease. And so essentially, any adult with conotruncal abnormalities, should be assessed in genetics and then followed in a multidisciplinary clinic. Any patient with non-cardiac manifestations but may have 22q should be evaluated for any vascular ring or vascular sling. So if they have breathing difficulties or feeding difficulties, looking for any vascular rings that may be there that their other cardiologists didn't necessarily identify. So if you're a teenager and you can't swallow solids and it's not because of velopharyngeal insufficiency, it may be because of a vascular ring, and you may end up getting a CT scan and a 3D model to see if there's any problems there with the vessels impinging on the food pipe or the air pipe. Our 22q clinic is unique to the Southwest. We've got 5-10 years of 22q experience here. You guys know already it's a single-day experience that's fantastic, 7 to 10 specialists, and it's truly personalized medicine. And in the cardiac realm, we are definitely looking at all the great details of the heart. And in that, I'm going to conclude that I'll be out here by the 3D table and go over any of the 3D models for you. And I want to get you, I think we're all caught up, Terry, in regards to the transition here. But thank you very much. Yeah.
Okay, thank you, Steve. That was fantastic. Wow. You stole my thunder about the clinic, but we're going to take a few minutes for questions. I'm going to ask Dr. Singh to come up, and I know you all have a few questions for each of them. Two of my team members, Vanessa is in the back with a microphone, and Peggy Kulch, genetic counselor, with a microphone. So if any of you have a question, raise your hand and they'll bring the microphone to you, because I want everybody to be able to hear the questions. And then we'll go from there. Anybody has a question? I want to echo, too, about the vascular ring, that I think it gets missed, and we often ascribe our children's feeding issues to their low muscle tone or developmental delay. And we have had some patients who've even been assessed once for a vascular ring with a negative result, and later were found to have one, or one child who I think had two. So I really want to keep that in mind.
Can we help you over there?
Hi, I have 22Q, and I'm 48. I've only known about it for about 6 years. And my question is, although I've had all of the cleft palate repairs anyone could ever imagine having, including the reconstructive surgery between my birth and my first year, just to survive, I also had a pharyngeal flap repair done at about age 12. My question is for a cardiologist, Dewey Point. Ever since my diagnosis, however, I don't think there has not been, from a doctor's viewpoint, anybody who's ever really checked into my heart. Because I do have, my youngest daughter has 22Q, and she's had very few surgeries, actually, thankfully. And I've had a couple of EKGs, I'm sure, over the years, but again, I've just never had a full check. And I don't know if there's anything going on with my heart, but there's just a lot of other issues I have. And again, my father has had triple bypass last year, so that's why I'm getting more concerned, because I mean, you know, and he doesn't have 22Q that we know of. He just has a lot of weird markers, if you will, that could possibly have it. But I'm just wondering why there hasn't really been a really full workup. Is it because I'm an adult now, and that's just out of curiosity? Should I encourage my doctor to really look into that?
Well, it's almost like you were planted in the audience to promote our clinic, our multidisciplinary clinic, but you are now a VIP red carpet invite to our multidisciplinary clinic. Because even though we're Phoenix Children's Hospital, we have no age limits. You know, you are a kid in our eyes. You were born with this 22Q, and we need to go through from square one, the full assessment, to make sure everything's okay. And I will be your cardiologist if you want me to be your cardiologist, and I'll make sure your heart's okay and your vessels are okay and that everything's okay. And honestly, we've done this for so long that we kind of have what the usual suspects are, you know, and so we'd be very targeted in looking at you in regards to making sure that you don't have some of the common cardiac abnormalities. I put this up here because technology is so cool. I mean, it's absolutely cool. I showed you some of the 3D printing, but if you have symptoms, you know, in regards to, you know, you have some chest pains or you have some palpitations, we may send you home on a fancy little monitor just to make sure that you're okay. You know, so it may be, and Kelly had mentioned it too, it's a painful process coming to the hospital and going through the clinic, but if we can all consolidate it on one day and we can see all the subspecialists and everyone's going to be focused on you, we will personalize your medicine to make sure that you're okay. We may send you home on one of these fancy monitors to be sure that your heart rhythm's okay. And I didn't get to that, but anybody who has cardiac abnormalities has always got an increased risk of having arrhythmias or palpitations where you feel your heart racing. And the monitors have gotten amazing. You know, they're almost close to Fitbits, but these are the latest and greatest monitors where you can just put a patch on there and monitor your heart rate for 30 days, 60 days. But we'll take care of you.
Just got a quick question. So my daughter has got 22Q. She had an open heart surgery when she was 5 months old. So they repaired the patch. They put the patch on. Secondly, she had another one about 2 years ago where they replaced it with a pig valve. So a couple questions that lead into this. One of them is they said that when she was 30, 35, she would have to get another valve put in. Is that a valve that goes inside the current valve there, so not one's removed and we put a new one in? And then secondly, she was just diagnosed with PVC about 2 weeks ago. So they put her on medication and we're seeing if that will solve that. Is that a common thing for that to happen? The extra beats and whatnot at the bottom of the heart?
Absolutely. And so the valve inside of her valve is almost like the Russian doll phenomenon. Okay. You need to be able to fit the new valve inside of her existing valve. Okay. And so size matters in that situation. The valves that are shown here and they're on the back table for break.
Sure.
Go from 18 millimeters up to 28 millimeters. So it really depends on what conduit was placed inside.
Okay.
So if she had a 24 millimeter conduit, no problem at all. Her next valve will likely be a balloon stent valve through the leg.
Okay.
If it's under 18 millimeters, it's probably not a good idea because then you're just making that space a little smaller, and she may need surgery with a bigger Russian dowel so that the next valve can be a slightly smaller Russian dowel that can fit inside of it. It has to fit inside.
Okay.
PVCs are super common. You know, I had a big latte this morning, and I'm having some PVCs right now today too. So it's like, but that monitor that I showed you is a godsend. So you have to measure how many they are. And if it's an occasional one after a latte or after excitement, no big deal. But if there's a lot of runs and it's in the area of where her heart surgery was, that could be like a little focal seizure of her heart, and that's important. She may need medicines or something to take care of it.
Yeah, they actually did put her on medication. I think it's more of blood pressure medication, whatnot, to see if they can clear that up. And
Yeah, the blood pressure medicines also kind of chill your heart out, so they
Gotcha.
don't twitch as much too. So it's probably doing two things.
okay, all right, appreciate that.
Sure thing.
I'm sure our speakers will be available here during the break. And we have one more question. Great.
Hi, my daughter had the Melody valve done in 2010. Now that she's going to be 20 years old this year, I'm trying to get all of her care together. She's been having, symptoms, hot flashes and things like that. My problem is getting her primary care doctor on board with her cardiologist. They're both on different pages, and so things are happening more rapid now for her. Do you have any suggestions for that?
Absolutely. So again, I'm plugging the multidisciplinary clinic more so because you don't know if the hot flashes have to do with those PVCs or some irregularities, or if, and this is the Melody valve up here, this picture, nothing that is not your own is perfect, okay? And I don't want to scare anybody on that, but it's like you reject things that aren't your own. So a Melody valve is supposed to last decades, and more. But 22q patients have a higher incidence of rejection, higher incidence of infection, higher incidence of many different things, calcium changes.
Yes.
And some of those calcium changes can cause you lots of symptoms. And the calcium can actually deposit on the Melody valve, or infections can deposit on the Melody valve. So I think it really requires a multidisciplinary team. We have our immunologists, we have our GI specialists, we have our geneticists, we have a huge team. So come on down to the clinic. I won't take over her cardiac care, but I will be the navigator and the concierge of cardiac care to assemble all of her data to make sure that we have all the appropriate things. And I'll try to rule out to make sure that her symptoms aren't cardiac related. But then we go to the panel at 4 o'clock in the afternoon after clinic, and we have a round table of 10 different specialists, and we go over your daughter's personalized care and say, why does she have these hot flashes? Why does she feel different this year than compared to the last year?
Yes.
And we come up with a plan.
Because her sugar's high, she's having issues, GI, so all these doctors are separately. We see Dr. Worsham here, but what I want to do is try to get everybody here together on the same page. Could she have like a primary care here, or would it have to be all individualized?
As part of the team, I sort of take that quarterback role, but I wouldn't replace your primary care physician, but I communicate with him or her, and our team compiles a report, and I coordinate any referrals, imaging, lab studies, and I'm more than happy to speak to her primary care physician on the phone and let her know what the team recommends. So
Okay.
while we don't replace, we definitely want to augment any services and make sure that it's all clarified for the PCP, because there's a lot of complex things going on, and we know our primary care physicians, who are very caring and well-intended, have less time during a regular visit to address all the issues you might need. So we're
Okay.
happy to work in conjunction with them.
Thank you so much.
Another question over here. Mr. Calcaterra.
I have a question for Dr. Singh. Our son, Charlie Calcaterra, obviously had the flap surgery, and he's currently, over the last couple of years, constantly blowing his nose, and he's producing as he's blowing his nose. Could that be structural?
So Kelly and I have spoken about this, but
Oh, okay.
no. It's okay, not to throw Kelly under the bus, but I think it's a great question because a lot of our children have pharyngeal flap surgery. What happens is that the mucus settles on top of the pharyngeal flap, and it's hard to generate enough pressure to blow it out. The desire is to blow your nose to try to get the phlegm out. The dry climate here doesn't help. It thickens the drainage and doesn't allow it to drain easily. And so kids are constantly trying to blow their nose, but you can't fully just attribute it to pharyngeal flap. You have to make sure there's no sinus issues like sinusitis related stuff, tonsils, adenoids. So we do have our ENT colleagues on our team who are also critical in doing kind of a comprehensive evaluation. But this is a common thing that patients who have had pharyngeal flap say to me. And so I recommend symptomatic treatment with cool mist humidifiers, saline sprays. Sometimes it becomes a habit because they've struggled for so long.
Thank you.
All right.
Anyone else? All right, I want to thank both of our speakers again and for really enlightening talks. And as Dr. Kofal said, so video games are not just for our teenagers, they're for surgical planning. So it's amazing. Yeah. Before we go on a short break, I just want to mention a really exciting project we're doing here in our 22Q clinic with our team. It's our genome project. I'm doing this project in conjunction with the entire team and primarily Dr. Pofall. And this study is a genomic study, we're calling it. What we're looking to do is understand better why the symptoms of 22q vary so much, not only from individual to individual, but also within the same family, where a parent may have very mild symptoms, and such as one of our participants said wasn't diagnosed till she was an adult, whereas we diagnosed her daughter at a much younger age. So that is not solely due to that deletion on 22q because it's the same size in most people. So there clearly have to be other factors, and that's what we're hoping to find. We are looking to recruit families, so if you have more than one affected member in your family, a parent and a child, we would love to have you participate. Our study involves, unfortunately, a little blood draw, but a physical exam by Dr. Pofall and myself, and we are doing some developmental type testing, neuropsychological testing on mom and dad, both parents if possible, to look for other factors that are involved in developmental outcomes. I want to introduce Rosio. I'm going to ask her to stand up. Rosio Ortega, she's our wonderful clinic research coordinator, and you can contact her by the phone number here or at her email, and we also have some flyers about the study that she has, and I believe I put some out in the lobby on the table, so please pick one up, and we'd love for you to participate. Thank you. All right, now we're going to take a little break. We're a little behind schedule, so we will start again at about 10:10 with the second half of our program. Thank you, and enjoy some refreshments. While we're breaking, we have a fun, exciting contest that we're going to conclude now. Okay, well, do you want to, Lori, tell us what this is, because
So I'm Lori. I'm from the Barrow Cleft and Craniofacial Center. We're located over at St. Joe's, and we do craniofacial speech, craniofacial orthodontics, and psychology over there. And Dr. Grebe asked if we could have a table. So out at my table, and we have an email list that you guys can sign up for. We do about one outreach program a month. We do a big holiday party. We have about 400 people that come. And then we have a cleft picnic that we do in the spring. And I'm trying to think what else. And then sometimes I just randomly get tickets to, like, we're going to go to an ASU baseball game at the end of the month. So if you guys just want to be in the loop for that, and I tell families if you don't want to do anything, at least be on my email list so you can find out what's going on. We have a donor that supports 100% of our program, so there is no cost to anything that we do for our programs, which is really nice. So I asked Dr. Grebe if we did a lot around the Wonder movie. So one of our outreach programs is if fifth grade classes are now reading the Wonder book, which turned into a movie. And once they complete that book, I have 2 patients that go out with me, and we do an hour-long presentation to 5th graders and give them an opportunity to meet people with the craniofacial difference. So I brought a couple of those books, and a cookie that looks pretty and it actually tastes good. So I have names. I'm going to let Dr. Grebe pick one. She can't see him and she doesn't have any preference for anybody, so. Here. And I like to win stuff, so I always have to bring something. Tanisha Keglin. I know, I was like, I remember Tanisha's name. Yay! All right.
Okay. Well, we're going to reconvene. Just going to minimize this for a second and welcome you back to the second half of our program. I want to just, things disappeared. Uh-oh. That wasn't good. Shouldn't have done that, because now my talk is on. Okay, wait 1 second. Okay, there we go. Oops, I do apologize. Okay. I just wanted to spend a minute to mention our clinic. I know Dr. Pofall has mentioned it, and many of you have been to our clinic, but for those of you who haven't, I wanted to just tell you a little bit about our team, our 22Q team. We started our clinic in 2014, and we're going on our 5th year, so we're 4.5 years. We do coordinate the clinic through our Division of Genetics and Metabolism, and if you haven't been, or if you want to come for a follow-up, and all of you do need your annual follow-up visits with us, you can request a referral from your primary care physician, and the clinic appointments are scheduled by my awesome clinic coordinator, Vanessa, who's helped me today. Can you wave, Vanessa? Thank you so much. Vanessa's helped me greatly this morning. You can also reach us via our email, 22qclinic@phoenixchildrens.com, or look on the Phoenix Children's webpage. We also have a direct phone line, 933-2252. You can reach us through the hospital operator. Our clinic runs once a month. We do reserve it to just 4 to 5 families because we want to make sure that we are able to provide you with a complete, thorough evaluation, personalized medical care plan. That's why we limit it. We have decided to divide the clinic days. Some days are designated as pediatric, so for our younger infants and young children, or teen or adult, because we feel it's important to not only provide you with the right care, but the right specialist, because our team varies just slightly from teen to younger child, and you get to sit together and have lunch together and meet Kelly, if you haven't met Kelly, but hopefully when you come, she'll be there again like she's been. This is just a list of our team. We have our core team, and you've met our craniofacial surgeon, Dr. Singh, Dr. Pofall, our cardiologist, myself, our genetic counselor is Brittany. Peggy's filling in today, thank you, and our large team there. But we also have a virtual team I just want to mention, and these are specialists that you may need, you may not have seen, you may need to see. They aren't with us the day of the visit, but I have designated go-to people here at PCH who are willing to help us out, and I refer to them when needed. 2 members of the team you wouldn't see the day you come are our endocrinologist, Dr. Newbern, and our immunologist, Dr. Wong, but they come to our post-clinic meeting and discuss all of your needs and help me to determine what studies might be needed, referrals, imaging studies, and so forth, and then we create a comprehensive care plan for you, which we send to you and to your primary care physician. So please come back if you haven't been back in a while, and consider coming if you haven't yet. This is just a table of our numbers. We've seen, since our inception, 153 new patients, 28 follow-ups. We are trying to make room for follow-ups, but we have so many new babies being born that we are struggling a bit to meet everyone's needs, so we're trying to find ways to expand. So we've seen a total of 181 patients so far in our 4 years. We have many more scheduled out through the fall, I believe, but we'll do our best to accommodate you. And if you have any urgent needs, please call me. If we don't have a slot in our team clinic, you can certainly come to see me in genetics clinic, and then I'll do my best to help you get the evaluations your child needs. So that's our clinic.